Paula said she was coming. Okay. Okay, so you, rather than Paula, you ready to start now? Hold this close up.
Good afternoon. You ready? You sure? All right. Good afternoon. Welcome to the Bessie Smith Culture Center. And this, I think, is our third series in our Minority Health and Health Equity series. Certainly, we've been happy to put these on. We had some great discussions and great panelists, and we're looking forward to tonight's panel discussion on kidney failure and organ donors. Tonight, we'd like to welcome all of you all, those of you who are in television land, live streaming, and those of you who are here live. We thank you for being here. Certainly, this would not be possible without the sponsorship of the Mountain City Medical Society, the City of Chattanooga, Bessie Smith Cultural Center, and CHI Memorial. So we thank all of you all for doing what you do to help us put this on. Without any further ado, I'm going to welcome Sister Willie Mae Hubbard, Dr. Willie Mae Hubbard. She's been a friend of ours for so long, she feels like a sister. We worked together back in the early days of the 70s in the health centers and things of that nature. So I just feel akin to her. And I'd like to just welcome her, and she would introduce the panels tonight. Dr. Hubbard.
Good evening, good evening. And again, I would like to welcome you to this evening and to thank everybody for participating, because this is a very, very important issue, particularly in our community. Chronic kidney disease, I'm focused on liver, chronic kidney disease, end-stage liver disease, kidney disease, and transplantation. I am a longtime pediatrician in the Chattanooga area, as Eli has said. And this afternoon, or this evening, I would like to introduce our panel for this third in a series of panel discussions. Our first presenter tonight will be Dr. Shayla Toombs Withers. She earned her doctorate degree in osteopathic medicine from the Edward VA Virginia College of Osteopathic Medicine and completed residency training in family practice at the University of Cincinnati and Christ Hospital. She has also completed additional fellowship training in obesity medicine and holds a certificate of plant-based nutrition. Her basis for health is in the line with two of her favorite quotes: "An ounce of prevention is worth a pound of cure, and let food be thy medicine." Our second presenter is Dr. Prince Ariete. He did his undergrad and received his medical degree from the University of Ghana. He completed his residency and chief residency in internal medicine at Meharry Medical College in Nashville, Tennessee. Completed a fellowship in nephrology at UT Southwestern. Dr. Ariete is board certified in internal medicine and nephrology. And lastly, Mr. Michael Clay. He is Director of Family Services at DCI Donor Services based out of Nashville, Tennessee. With over a decade of experience in several high-performing organ procurement organizations across the country, he provides direct support to a committed team of compassionate family support leaders in Tennessee, New Mexico, and Northern California. Michael served as the Director of Family Care at Southwest Transplant Alliances, Manager of Family Support Services at Louisiana Organ Procurement Agency, Manager of Family Services at Nevada Donor Network, and Family and Hospital Services Coordinator with New Mexico Donor Services. And now we will begin this discussion, and Dr. Toombs will lead it off with giving us some healthy tips and focusing on the prevention of those conditions that will result in end-stage kidney disease. And Dr. Ariete will discuss the prevalence, evaluation, and management of end-stage kidney disease. And Mr. Clay will end the discussion with how organ donation and transplantation can impact and greatly improve the quality of life of those in need and seeking transplantation as an option to improve the quality of life. And now the discussion begins.
All righty. Well, thank you so much, Dr. Hubbard. I am Dr. Shayla Toombs Withers from Essence of Health Wellness Clinic and Coaching. Thank you all for having me today. So I'm going to start, name the title of this, Healthy Being, Stand Healthy to Protect Your Kidneys. I'm sorry, and I think we were going to have slides. I don't know if they're showing. Okay, there we are. So if you can go to the third slide there. Yep, next slide. All right, awesome, thank you. So I wanted to start just by really briefly telling you about what your kidneys actually do. You know, most of us, we know we have kidneys, but what do they do? So our kidneys have some very important functions. They remove waste and excess fluid from our body. They remove drugs and toxins from our body. They release hormones that actually help to regulate our blood pressure, promote healthy bone growth, control the production of our red blood cells, and balance the electrolytes and minerals within our bloodstream, which is why your doctor may sometimes do that kidney function test, which I'm sure many of us have had. Next slide. Now, in terms of what causes kidney disease, which is why we're here today, diabetes and high blood pressure or hypertension are the two leading causes of kidney failure in the United States, actually accounting for about 75% of new cases. Chronic kidney disease can progress to become kidney failure. 15% of adults in the United States, which equates to about 37 million people, have chronic kidney disease. African Americans are almost 4 times as likely as whites to develop kidney failure. And this is mostly in part due to our increased rates for chronic health conditions like diabetes and high blood pressure, which puts us at an increased risk for then developing kidney failure and chronic kidney disease. Next slide. When we discuss diabetes and kidney disease, so when you have diabetes that progresses on to kidney disease, it's called diabetic nephropathy or diabetic kidney disease. African Americans and Hispanics get diabetes more often than whites, as we discussed, and African Americans and Hispanics who then have diabetes will develop kidney failure even more often than whites who have diabetes. About 1 in 6 African Americans, with diabetes are unaware that they even have this condition. And this is for a number of reasons. Some of this is socioeconomic factors, lack of access to quality care. These are reasons why we may not even realize that we have this health condition. And then about 1 in 3 Hispanics living in the United States are uninsured and less likely to be aware of their condition, which also is why these minority populations are at increased risk. Next slide. So what contributes to kidney disease when you have diabetes? Well, it's high blood sugar. When you've already been diagnosed with this condition of insulin resistance that tends to make you have higher blood sugars like diabetes, and then you over time continue to have those high blood sugars, then it can cause damage to those blood vessels in the kidneys, which makes your kidneys unable to function properly, that function that it has in filtering out those toxins and those drugs, those things we talked about. It also damages the nerves in the body and affects your body's ability to detect those messages from your bladder. That also leads to kidney damage because you're not able to empty your bladder properly due to that damage from your high blood sugars. Furthermore, bladder dysfunction can be due to nerve dysfunction, makes you retain urine, and then can increase your risk for urinary tract infections. Bacteria actually grows and thrives in sugar. I don't know if any of you all or your kids or grandkids ever did the little science fair projects, and you can actually see that bacteria where it thrives in sugar, or even just thinking about cavities in your teeth too, that causes that breakdown there. And so urinary tract infections can then go on to cause that kidney damage. And when you have diabetes and you've had these frequent infections, then that can cause further damage. Diabetes also increases your risk for high blood pressure, further increasing your risk of kidney disease there. Next slide. Let's discuss high blood pressure and kidney disease. 55% of African American adults have high blood pressure. Black Americans tend to have even more severe high blood pressure conditions and even develop high blood pressure earlier in life than our white and other counterparts. And then uncontrolled high blood pressure can go on to cause strokes, heart failure, and kidney disease. I put this picture here with the blood pressure numbers because for a lot of people, they think, well, my blood pressure is actually considered good or, it's in that 120 to 130 area, and within that 80s area. But if you actually look at this graph, which is from the American Heart Association, your blood pressure is actually considered elevated if it's in that 120 range, and it actually should be below that 120 over 80. So keep that in mind, as high blood pressure can contribute to kidney disease. Next slide. High blood pressure causes a narrowing of your blood vessels, which then reduces proper blood flow. And that then in turn causes damages to your kidneys. If you look at this picture here, you can see the kidneys and the blood vessels in the heart, because these things are all interrelated. And excuse me, once you have damage to one, it can go on and cause damage to the other and also increase your risk for damage to the other. When you get kidney damage from high blood pressure, that causes an inability to remove waste and balance those fluids properly within the body. And then that extra fluid can raise your blood pressure, thereby causing more kidney damage. So it's kind of like a double-edged sword there. Next slide. Now that I've given you all these stats and facts and figures, I'm gonna put this in here because there is a solution, and then we're gonna get to the preventative piece of this. So if you scan that, you will go to a course. It's called the Nourish and Flourish. It's a free 5-day course, and it's actually all about nutrition and health tips, healthy recipes, things that you can do to jumpstart your health, things that you can do to prevent health conditions like diabetes and high blood pressure and kidney disease. And so I want you to take a look at that. I want you to sign up if you need that jump start. All right, next slide. Now, so really the key to preventing kidney disease is really to tackling those conditions we talked about, the diabetes and the high blood pressure. And one of the best ways that you can do that is to put more plants on your plate. I know we've all seen the Chick-fil-A cows, and they tell you to eat more chicken. Well, this cow is telling you to eat more plants, okay? And so, you know, when you reduce your consumption of meat, dairy products, animal products, ice cream, all of the oils, cheese, all of those things, it can actually improve these health conditions. Reducing your consumption of those highly refined grains, those processed foods, so things like breads, muffins, sweets, donuts, potato chips. Reducing your consumption of those things can, you know, improve your health conditions. Reducing your consumption of oils. For a long time, we, you know, commonly thought that, well, if I use olive oil or if I use coconut oil, then that's healthy. Well, no, it's actually healthier for you to eat those foods in their whole food state. So it's better for you to eat the olive instead of use the olive oil because it's been broken down and refined, and that amount of oil just increases your amount of saturated fat that you're putting into your body, and that saturated fat leads on to those things of high blood pressure, leads on to insulin resistance and diabetes, and increases your risk for conditions like kidney disease, as we're discussing. And then reducing your consumption of sugar, syrup, salt. Those foods, those products are really put in foods to make us eat more, and they're the common ingredients that are found in those processed foods, those things on the shelf that we tend to know aren't good for us, but we crave them because they have those components in them. But reducing your consumption of those foods can actually help to prevent kidney disease and diabetes and high blood pressure. And so I titled this Healthy Beans because some people refer to the kidneys as their beans, but actually eating beans is a good way to prevent kidney disease. Beans are high in protein, beans are high in fiber, and high in nutrients, and a good source of carbohydrates. Beans are cheap. We can easily access them. They're cheaper than meat. And they're really good for you. The protein in beans will actually process, and your body will utilize those in a way that will be more healthful, that will actually reduce your blood sugar because it's not going to give you those same spikes. It's not going to put that same amount of saturated fat into your system versus a meat protein source there. Other unprocessed foods, you want to consume more unprocessed whole grains. So that's like brown rice, quinoa, barley, farro. Those are things that you want to consume instead of your typical breads and pastas and those types of things. You want to eat fruit. A lot of times, I've even had some of my diabetes patients say, well, I was told I can't eat fruit, or if I eat an orange, then my sugar is going to spike. Well, that's just simply not true. It's because of the way that, you've developed this key of insulin resistance. But nobody's ever developed diabetes from too many apples. You just will not find that study out there. So eat fruit. Fruit is high in fiber, especially the fruit with the skin on it. So apples, blueberries, plums, you want those things. Those high fiber foods will actually help your body to process sugar better from the fiber there. And then dark leafy greens and cruciferous vegetables. So that's your collards, your spinach, your kale, your broccoli, your cauliflower. All of those foods too are really good for you. Those foods also contain certain pigments within them that give them their color, but are also natural anti-inflammatories for you. So they will actually help to reduce your blood pressure and reduce conditions like chronic kidney disease because of the natural anti-inflammatories within those foods. Next slide. The next key to prevention is to get up and move. When we move our body, it actually decreases our risk for those health conditions like heart disease, stroke, diabetes, and high blood pressure that go on to contribute to chronic kidney disease. Moving our body also helps us to sleep better. It reduces insomnia and obstructive sleep apnea. What we know about conditions like obstructive sleep apnea, is that it can increase your blood pressure, and like we talked about, blood pressure can actually increase your risk for kidney disease. And then with insomnia, when you're just not getting quality sleep, then that raises things like your cortisol levels and makes you more insulin resistant, makes you more likely to hold on to weight and weight retention, and all of those can increase your risk for diabetes and high blood pressure, which can go on to kidney disease. Moving our body helps us to achieve a healthy weight, reducing risk for those obesity-related health conditions. It helps us to develop strong bones because like we talked about, when we have kidney disease, it actually can affect our bone growth. And then it boosts those natural endorphins, which are those happy hormones within our brain to reduce those symptoms of depression and anxiety because once again, stress can contribute to uncontrolled diabetes and uncontrolled blood pressure, which can turn into kidney disease for us. Next slide. So that's all I have for you. The essence of health is in you. Thank you.
I'm Dr. Prince Aite. I am a nephrologist in town. We have practices on Lally Street, as well as in Ottawa and Cleveland as well. I'm going to be talking to you about end-stage kidney disease and dialysis. So I'm going to talk to you a little bit more about your kidneys as well, because that's why we're here. The first thing I would like us to know is that a lot of the times I get questions about, back pain and kidney disease. Your kidneys are actually located a little bit higher than most people think. And so when people come to my office and complain about back pain and think it's from their kidneys, a lot of the times it's just good old back pain and not from your kidneys. In fact, your kidneys rarely cause pain. There are very few circumstances in which that happens. If you're passing a kidney stone, sometimes you can feel pain. If the kidney is infected significantly, yes, you can feel some pain. If you've got a cyst as well in the kidney, which tends to be common as we get older, and that cyst ruptures or you bleed into the cyst, then sometimes you can get pain. But aside from these, very rarely does the kidney cause pain. The main job of the kidney is basically cleaning your blood. That's the number one job. A lot of the times patients ask me, well, you say I have kidney disease, but I'm peeing fine. Well, making urine is actually the easiest thing for the kidney to do. So there are a lot of dialysis patients who have been on dialysis for a few years who actually still make urine. The main thing is your kidney cleaning your blood enough to sustain life. That's the bottom line. Your kidneys also will make certain important things, hormones, like Dr. Toombs mentioned. Erythropoietin is one. Activated vitamin D is the other one as well. Both kidneys work in tandem. So when your kidney fails, it's not just one of them that fails. I get that question a lot too. Is it both kidneys that have failed? Yes. Unfortunately, both kidneys are exposed to everything else that you've been exposed to all your life. So all the diabetes, all the high blood pressure, all the heart disease, all the high cholesterol, all of that, both of them has been exposed equally. And as such, when your kidneys, are failing, both of them would fail. Next slide. So how does your kidney accomplish all these? Your kidneys basically are made up of things called nephrons. That's what, is considered the working unit of your kidney. You're born with thousands of them, almost 1 million in each kidney. Now, their job is to filter your blood. In other words, they get access to the water part of your blood, and then once they've filtered it, they'll clean it, reabsorb all the good stuff, and then all the stuff that is waste will be, thrown in urine. The filtering ability of the kidney is usually described as, glomerular filtration rate, or the GFR. So a lot of the times your doctor will tell you about a GFR number. The higher that number is, the better, your kidneys, function. Your kidneys will also adjust your blood pressure as well. It will also adjust, your acid and your base levels in your blood. And your kidneys, like I said earlier, will also make, erythropoietin and activated vitamin D as well. So let's talk about end-stage kidney disease now. End-stage kidney disease, it's a permanent state. In other words, again, I get a lot of questions about, is this reversible? Are my kidneys gonna get better? Oh, I think I'm gonna wait a little bit longer, drink a little bit more water, and hopefully the kidneys will get better. Well, once your doctor tells you that you're at end-stage kidney disease, it's a permanent state. There's no recovery from that. A lot of the times, it's a state in which that GFR number we talk about, that filtering ability of the kidney, is less than 15 milliliters per minute. It also means that kidney replacement is needed. And kidney replacement can be in, one of two forms. It's either you get dialysis, which is, is always meant to be a temporary treatment, and then the definitive treatment is usually a kidney transplant. The next slide is meant to show you what the prevalence of end-stage kidney disease is, and this data is from United States renal data system. It shows on the y-axis you've got cases per million persons, and then on the x-axis you've got the years in question. But the bottom line is that chronic kidney disease essentially basically goes up. End-stage kidney disease basically increases as as we all get older. The kidney is like everything else in our body, has a lifespan, and also as you get older, you're more prone to a lot of these chronic conditions that we've talked about: high blood pressure, diabetes, high cholesterol, heart disease. And so you'll find that, let's see, individuals in the blue and the green, that is ages 60 to 74 and 75 and above, there are about, over 6,000 people per million that are living with end-stage kidney disease in 2020. Next slide. The next slide is meant to show what the prevalence of end-stage kidney disease based on ethnicity. And as you can see, that red line is all the way up there, and that is for the black population. Minorities are kind of all the way on top. You're looking at 6,000 and above cases per million persons. Next slide. So what are the causes of end-stage kidney disease? By far, the most common cause is going to be chronic kidney disease. That's number one. And chronic kidney disease is a progressive disease. In other words, once you're diagnosed with chronic kidney disease, over time, your kidney function will go down. It's a progressive disease where there's a gradual loss of kidney function, or sometimes what we see are markers of kidney injury are present. In other words, your doctor may tell you that you've got some protein in your urine or you've got some blood in the urine. The commonest cause is high blood pressure and diabetes. That will account for most of the cases of chronic kidney disease. There are stages, which some of you may be aware of already, stages 1 through to 5, and that is based on that GFR number that we talked about earlier. There are some other causes of chronic kidney disease besides hypertension and diabetes. There is sometimes if you have long-standing urinary obstruction, especially men as they get older and the prostate becomes bigger, sometimes you can get profound urinary obstruction that can go unnoticed for a while. That will cause the kidney to progressively lose function as well. Then there are some autoimmune diseases and some inflammation of the kidney states that can become chronic, where over time the kidney function will also go down. There are some genetic cyst disease like ADPKD that will also do that. And then, the simplest one that I find a lot is, patients taking ibuprofen and NSAIDs, as we call it, chronically over years and years and years. And then by the time they arrive at, age 50 or 55 years, kidney function has gone down. And while they don't have high blood pressure or diabetes, but then, well, how have I lost all this kidney function? Well, and that's probably because, of these medications that are over the counter. They're great pain medications, but unfortunately, if you take them over a long period of time, it puts the kidney at risk. The second cause of end-stage kidney disease is what we call acute kidney injury. And in this case, instead of a slow progressive loss, you suddenly have significant loss of kidney function in a short space of time. A lot of the times when we say acute, it's because there's a chance that you can make a complete recovery or partial recovery, and sometimes you don't make a recovery at all, so you just go from acutely losing kidney function to end-stage kidney disease. A lot of the time this occurs in patients that have sepsis and end up in the ICU for a long period of time, and they end up needing dialysis and basically never come off dialysis after they are discharged. What are the symptoms of end-stage kidney disease? Remember, when we say end-stage kidney disease, we're talking about a permanent state. So once you get to this point, you are more than likely needing either dialysis or a kidney transplant. A lot of the times, you have a situation where a lot of toxins build up within your blood, and that can cause a lot of nausea, vomiting. You can also have generalized swelling, because one of the jobs the kidney does is actually, pee and make urine, and basically get rid of the excess amount of water that you drink. That can stay and cause swelling. You can have shortness of breath as well. And then there are changes in appetite. You lose appetite. And then the taste of food sometimes changes as well. A lot of patients describe it as being metallic. And then sometimes, your breath actually smells like ammonia when you've got a lot of toxins built up. The blood pressure goes up, electrolytes begin to accumulate in your body. You have high potassium, phosphorus, you begin to develop anemia. These are all indicators that you need dialysis or you need a kidney transplant. I'm going to talk a little bit about kidney replacement treatments. As I've mentioned, kidney transplant and dialysis are the options that we have available. Dialysis is always meant to be temporary whilst you hopefully get on the donor list and get a kidney transplant. Averagely, it takes about 3 to 5 years to get, a kidney, from, the deceased donor registry. There's also living donor kidney transplant as well, which hopefully there'll be more kidney donors as we all get more, a little bit more educated. You can live with one kidney perfectly, and that's why we transplant people. So that's always another, option. Dialysis, like I said, replaces your kidney. It does not fix the kidney. Neither of these treatments fix the kidney. They basically replace the kidney. So I get asked a lot, is dialysis going to fix my kidneys? The answer to that question is no. It's just replacing your kidneys when you have end-stage kidney disease. There are two main types: peritoneal dialysis, which is one that uses a catheter in the belly. And basically, you put in fluid in your belly to use your peritoneum, which is, the lining within the abdomen, to, clean the blood and also basically help you manage your fluid status. Peritoneal dialysis you have to do every single night, and so some patients get a little uncomfortable with that and say, well, I prefer to go somewhere and have a professional do my dialysis for me. Both peritoneal dialysis and hemodialysis, which is the other option, works just as well. It's just a case of choice. Some people like to work whilst on dialysis, and that is good. So they like to do their dialysis at night, and suddenly peritoneal dialysis allows you to do that. You do it yourself, and during the day you can go to work. The second type of dialysis is hemodialysis, as I've just mentioned, and that basically uses your blood. Your blood basically goes into a machine that has a filter, and the filter basically just cleans your blood and returns your blood to you. A lot of the times we use something called a fistula, and that's the ideal way to do it, is to get a connection between an artery and a vein in your arm, and that is what we stick at dialysis to get access to your blood to clean. Sometimes if you wait too long, then you get all of these symptoms that I've just mentioned: nausea, vomiting, a lot of swelling, shortness of breath, and we have to use a catheter to start you with your dialysis. That is always not ideal. And so the preference is that you begin to, plan with your nephrologist or your doctors ahead of time so that you can get a fistula in. These fistulas can take up to about 6 weeks to about 6 months, sometimes, to get ready to use. And that's why it's always good to plan ahead. Hemodialysis is typically done 3 times a week. And a lot of the times you're doing it over 3 to 4 hours. These days, you can do hemodialysis at home as well. A lot of patients have been trained to stick the fistula themselves at home and get, the dialysis done at home. The advantage of that is that sometimes you need an additional treatment, which you can then do at home. You don't have to wait to get to the center to do that. I think that's about all I have for you tonight. Thank you.
Hard act to follow. Very informative. I'm kind of doing some soul searching right now on some of the information I just heard in regards to my family history and experience with. But so we've talked about kind of the three components: the outward facing, the healthcare, the self-care, the diet, which was really profound, and thank you. And then we've talked about, from a more granular clinical perspective on what this is and how it impacts us in the treatment. And the treatment, dialysis, very painful, very agonizing to see someone go through dialysis. And then we talk about the donation piece, getting life-saving gift and how that works. And that is my role here today, very briefly, to walk you through what that process looks like and how Tennessee Donor Services helps facilitate that for all of our Tennesseans. So what is Tennessee Donor Services? Tennessee Donor Services is an organ procurement organization regulated by CMS, UNOS, and other regulatory bodies. We are one of 57 across the country. Tennessee actually has 2. We also have another sister out in Memphis, which serves the western part of the state, Mid-South Transplant. OPOs, organ procurement organizations, are responsible for recovering organs, keeping the organs viable until they are transplanted. Recovery, we're on the recovery side, not on the transplant side. And transporting the organs to recipient transplant teams. Tennessee Donor Services has been serving this community for almost 50 years for all of those in need of organ and tissue transplant. So looking back at last year, we had 445 organ donors, 1,129 organs transplanted, or as we speak to, lives saved, and 2,346 tissue donors, and 606 birth tissue donors. Looking at 2023, we've had a really strong, profound year. We're going to move far past this number in regards to donors and lives saved. So we're working diligently every day, 24 hours a day. And that's something I want to speak to too about your organ procurement organization. We have people literally working 24 hours a day, 7 days a week, on holidays. When you guys are at home with your families, we have people in hospitals at bedside helping support families. So what organs and tissues can be used and what lives can be saved? We have heart, lungs, liver, kidneys, intestine, pancreas. Looking at the tissue side, cornea, various tendons, heart valves, veins, skin, and bone. So we talk about the process, and it's we look at it within about 7 pieces. The weight, there are 100 lives saved every day. There are almost over 100,000 people waiting for the precious gift. 60% of those people are people of color. I repeat, 60% of those people waiting for the precious gift are people of color. One donor can save up to 8 lives, but less than 1% of all deaths actually allow for organ donation to happen because they must be in a hospital and they must be on a ventilator. And that's one of the things we encounter quite a bit. My area of focus is 100% focused on family support. My teams work at bedside of people that are potentially going to withdraw support on their loved one, or their loved one has been pronounced brain dead. And so one of the things that we get a lot is people think donation is very common, but in actuality, it's not. Also understanding that of that percentage of folks who die, 0.8% of them actually get pronounced brain dead. Brain death opportunity gives us the most opportunity to save as many lives as possible. The referral to the OPO. Hospitals within our donor service area partner with the OPO and refer patients who will not recover or sustain a non-survivable injury. Only then will Tennessee Donor Services evaluate whether donation is possible. It's a very stringent, strict process which OPOs and our hospitals have agreed upon to refer patients when they meet various clinical triggers. Authorization piece, this is very important. Organ procurement organization determines donation potential, then compassionately requests permission to proceed with donation from that family's legal next of kin. The other pathway is when that patient is registered, the common method. Then there's a presentation of that document of gift. There's a presentation of that document of gift which states the loved one's wishes to donate organs upon death. Looking at organ matching, OPOs work diligently, like we talked about, 24/7 to match organs with patients who need them the most. This process requires cooperation of transplant centers and surgeons across the country. Gift of life. The OPO honors the donor and their selfless gifts, coordinates organ recovery surgeries, and ensures organs are safely transported to the transplant teams who care for the waiting patient. I want to speak to this too. A lot of this happens late at night when we're all sleeping. Our teams, OR availability is something that can be hard to come by in some of our busier metro hospitals. So a lot of these surgeries and a lot of these transplantation processes occur in the wee hours of the morning when we're all sleeping. Caring for donor families. The OPO team provides ongoing bereavement support and services to donor families and hosts memorials honoring donor heroes and their life-saving gifts. Why is donation important? Over 100,000 Americans are waiting for the transplant. 3,000 of those patients are in Tennessee. Every day, 100 lives are saved through organ donation. Every day. Still, 20 patients will die each day waiting for the precious gift. So, every 9 minutes, someone is added to the waiting list. That time has gone down quite a bit, which I'm proud to see in my almost 13, 14 years. 83% of those waiting for organs are waiting. 83% of those patients are waiting. Couple transplant facts. Keeping up. As a good doctor said, average waiting time is 3 to 5 years. Kidney transplant success rate is 95%. Living kidney donation is a viable and needed option as the number of patients waiting far exceeds the number of donors. So looking at those waiting for kidneys in our community, you can advance the slide, please. One thing I like to say a lot, and my staff probably just roll their eyes, but data removes drama, right? 48% of all those waiting for kidneys are from the Black community. 48% of those waiting for kidneys. Looking at the Tennessee wait list, there's 2,900 people waiting for the list. 45% of those are from the Black community, 48% are from the white. Part of this list. Looking at the Tennessee registry, meaning those people who have actually registered to be an organ donor, there's 2,780,000 of them. Now this is what is kind of scary. Only 9% of those are Black. In comparison, we make up 45% of those in the need. Looking at 85% of those folks registered are white. They make up 40% of the need, 48% of the need. There's just a huge gap in those registered versus those who are waiting. And it's something that we can take control over and help save more lives. Why does diversity in donation matter? Critical factors for donor and recipient matching, like compatible blood types, are more likely to be found among members of the same ethnicity. more likely to be found among members of the same ethnicity. Transplant success rates increase when organs are matched between members of the same ethnic and racial group. A couple facts I want to throw at you. These are facts. If you are sick or injured and go to the hospital, medical professionals will do everything they can to save your life. The medical teams who work to save your life are not the same as those who are involved with organ and tissue donation and transplantation. Big misconception. In fact, almost everyone, regardless of age, can donate something to help others. Most medical conditions do not prevent donation. Age and health criteria are evaluated on an individual basis at the time of death. People of all ages are given the gift of life. In most cases, donation does not interfere with an open casket viewing. Before moving forward with organ and tissue recovery, families are provided information about donation and answer all questions to ensure the OPO understands their wishes. As with any surgical procedure, the body is treated with the utmost respect and care. I came into this industry in family care. I will retire from this industry working with families. Myself and my crew are family care coordinators. In some places they call them family advocates. Once we are dispatched, we are tasked with working and supporting and leading that family through, majority of the time, the worst day of their life, through this whole donation experience. We are their liaisons through this end-of-life care. Responsible for presenting them the opportunity of donation or the acknowledgement of their loved one's wishes, and we are their chaperone, so to speak, through this entire process. Most organ donation cases take anywhere from 24 up to 72 hours. That's the time it takes to evaluate, treat, maintain, and find recipients. But we have Tennessee has typically people who are assigned at bedside to support families through this entire process. So they have a warm face on the majority of the worst day of their lives. So fact, all major religious organizations encourage organ, eye, and tissue donation as an altruistic and charitable act. If a religion does not have a written statement actively supporting donation, it supports an individual's personal choice. And here's how you register. My advice when I tell people what I do, after I tell them I work in organ donation, awesome, or I get kind of an eye roll. Wow, interesting. So you're going to take my organs? And no, ma'am, no, sir, absolutely not. And then I go into kind of my spiel. But I always tell people to do two things. Talk about your decision with your husband, your wife, your family. Talk about your registry decision that you made. Other thing, too, is within our community, we don't talk about death. We don't plan for it. And that's one of the biggest things I encounter with working with African-American families across the country. Is we don't talk about death. Something that there's a big opportunity, increased organ donation awareness, but increased planning around end of life within our community. It's something that we don't. My time is done. Thank you all very much for this opportunity.
Well, we certainly want to thank all of our presenters, and as many of you know in the audience, I am the recipient of a liver. I had my transplant in 2015, and oh my goodness, I went through all of these stages, all of the information that's been provided. I am well versed on it because I have become an ambassador and I work for Tennessee Donor Services that's here in Chattanooga. This touches my heart, and I really, really want to just emphasize again the importance of us understanding that we only make up 13% of the population, and yet look at the percentage of us that's on those transplant lists. And we have to understand that we need to learn about this, understand that it's very acceptable, it's very rewarding, and it saved lives. This is a wonderful gift to give, and I sit here and just am so thrilled that this one person made the decision, and I am a recipient. So thank you very much, and I'm just so touched by that discussion. But we have had a wonderful presentation, and I want questions from the audience. And Eli, you're going to be the first one.
Well, we have several questions
Okay.
from our online people. First question, what can be done to give access to this education in poor and working communities in the African American communities here in Chattanooga? That's an online question
It was,
for anyone. For anyone.
what you
I think
asked-
from
You want the question again?
Tennessee Donor Services, we have outreach group, an outreach team that can help facilitate. I just think the more we know about the events, the planning, the better we can mobilize to have the appropriate folks there to participate.
Okay, thank you. And our next question, after a successful kidney transplant, what kind of long-term support, follow-up care do donors and recipients typically receive? And I guess that's for anyone.
So from a medical standpoint, most recipients of a kidney transplant are actually seen very regularly in clinic. Starting from weekly visits or follow-up with your transplant nephrologist, until after about a year or two, you are really strictly under the care of your transplant team, which includes, your transplant surgeon, your transplant nephrologist, your transplant care coordinators, and you're pretty closely tied or linked, to your transplant center. This is all to, ensure that, the outcome is successful, because it's a huge investment on the front end, financially, and again, donation from, someone, and so you're followed pretty, closely.
Okay, and that's probably bring us to our next question, and that is there a permanent amount of financial assistance programs for people with the end-stage kidney disease in the Chattanooga area?
I am aware that the Kidney Foundation provides support to some patients. A lot of patients that are, diagnosed with end-stage kidney disease also end up on Medicare, I believe. So there is, yes, there is some support, yes.
Either Medicare or Medicaid, probably.
Mm-hmm.
And the next question, what would be the process for evaluating kidney donors?
So that's a very strict process, for living donors. On the one hand, you want to make sure that the donor themselves, are going to be able to go through life with one kidney. So you're screened pretty strictly. For the recipient as well, you are also screened to ensure that you can undergo surgery. And then, post-transplant, you also need to be healthy and strong enough. You're screened for things like cancers, on the front end, because you're going to be immunosuppressed, or they're going to suppress your immune system, after you've received, the transplant.
That's a question I get quite often. Typically, it's someone asking how a loved one can get listed, or what are the steps.
Are there any questions from our audience?
This is for Dr. Toombs. You were talking about different foods that we could eat, and I heard your list, but I didn't hear anything about oats. And some people eat oatmeal every day and think that that's good. What do you say about it?
Yeah, thank you for that question. Yeah, oats are actually wonderful to consume. Oats are a great source of fiber as well as a great source of protein. Where we tend to get in trouble with oats is that a lot of us buy the instant packets. And those packets, while they're quick and easy, they also tend to contain a lot of sugar. and that's gonna, totally undo the whole reason that you're probably consuming those oats. So it's best to just purchase in bulk. They're actually cheaper if you purchase them in bulk, and it's best to get them the least bit refined as you can. So actually still cut oats are gonna, be the highest quality of oats that you can get. And then when you cook them, you want to cook them in water or in a non-dairy milk, unsweetened type of milk, and then use berries or fruit as your sweetener instead of the processed sugar, so that you still get those health benefits from your oats.
Thank you. I was going to ask you about the still cut oats.
Yeah, still cut oats are actually a great choice. Yeah.
That was just a wonderful presentation. My question is for Dr. Toombs-Withers. So I'm a cardiologist, a heart doctor. My name's Megan Coyle-Wright, and I came with our Chief Diversity Officer from Erlanger, Liz Appling, and we are really passionate about prevention also. And so my question for you is about hypertension or high blood pressure. We all have family and friends that have high blood pressure, and when we talk to them about it, they say, it's okay, it's just my number's high because I just rushed in, or maybe I didn't sit down long enough. How do you really get that message home that it is important to get the number down? Are there some phrases you've used that have been successful that we might borrow?
That's a really good one too. Yeah, and I hear that too from my patients too. That it's high because of this A, B through Z reason. Everything except those lifestyle things that many of us don't want to pay attention to. But the way I approach it really is I'll start off by if it's not like dangerously high, having them go home and measure it and let them see for themselves what it's doing. So what is it when you're in your comfort zone at home, before the kids are bothering you and all these other things, and what's it look like? And then I have them report back to me. I use a lot of telehealth within my practice, so they're able to send it via text or via email what those numbers are looking like. And then if they're still high, then even for them, they're like, oh, okay, I guess you were right kind of thing, and then we're able to address it. But then the other key really, a lot of times I find that it's the numbers really looking at like those labs, and not that you want them to develop those secondary things like kidney disease, but even just seeing those small changes, and it's like, hey, we are seeing this, microalbumin change, or we're seeing this GFR drop a little bit. So, we've got to make some changes here, and you've, got to do these things. And so that tends to help too. And then just really talking to folks about high blood pressure being a silent killer. We know that, we're aware of that, but really just kind of making that ring true to them that, you may not be feeling this, 160 over 120 that you're walking around with, but it's still doing a lot of damage to you internally. And let's not get you to the point of, having these secondary things. I came through the traditional healthcare system where we were, held to the typical 15-minute visit that's actually like a 7-minute visit by the time the MA and everybody does what they need to do. And it was really hard to have those conversations, but now, I take a lot more time with my patients in private practice, and I find that just really sitting down and getting down to those other things that may be contributing. Yeah, you may be working a job where you're working 12, 14 hours a day, or, your husband travels a lot, so you've got the kids a lot. And so these other factors that may be contributing, and kind of getting down to really those other more practical things too that can make a difference for those patients.
Very, very good information. Thank you so much. And I have a question. You have family members that talk to you about their visits to the doctor, and they come home and say, well, the doctor states that I may have stage 2 or stage 3, not cancer, but stage 3 kidney disease. So you go to 2, 3. Can you expound on that? Should you be expecting to go to end the stage, a different stage for the end of life, or what should they actually be doing if they are diagnosed with stage 3, for instance, kidney disease?
Okay, so This is talking about chronic kidney disease and the stages, if I understand correctly. Okay. So, as I was saying earlier, this is based on your GFR number. If you're, 90 to 100 GFR, we say you are stage 1. And then if you're between 60 and 90, we say you are in stage 2. And then between 30 and 60, we say you are in, stage 3. Most people that are referred to me will, the bulk will come in stage 3, actually. And, the management of, chronic kidney disease is mostly the same for these patients from stage 1, through to stage 3. Once you get to stage 4, it becomes a little bit more complicated with, things like anemia and the electrolytes being messed up. But between stages 1 and 3, the main thing is you're really trying to get hold of, the high blood pressure, the diabetes, the things that can injure the kidneys. Those are the things that you are trying to deal with. So, following a low salt diet, really controlling that blood pressure and not taking it for granted anymore. Also managing diabetes and ensuring that your A1C, it's, in the targets that it should be, typically less than 7%. And also getting on the right medications, avoiding, things that can harm the kidney, like the NSAIDs and, other things. Those are the things that you really want to, maximize.
Are there any more questions? Okay. First of all, I'd like to say thank you again to our panel. Dr. Hubbard, thank you for moderating.
And thank you all. Thank you so much. This has really been a wonderful discussion to really see prevention when it happens and other alternatives so that it's not, so that it's something people can live with. Chronic liver disease. I am stuck on the liver, guys. Chronic kidney disease. So thank you so much for listening. And if we don't have any other questions, Paula?
I'm just going to say this will be on the Bessie's YouTube channel so that you can share it with your family and friends after tonight so that you can share this information with them.
Do we have a word from our president, Dr. Mance?
Dr. Mance?
Everybody say a word, right? Well, I like to thank the panel. One of the things about the Medical Society, we're in the process of trying to develop a process how the community can be educated, and at the same time develop a process by which we can communicate with one another to understand the importance of good health. One man says, if you got your health, you got everything. If you have everything without your health, you have nothing. And I think that's one of the things we must be more aware of. Another thing I think Dr. Toombs was talking about, she deals with nutritional support, and she didn't really talk much about nutrition. Could you basically, one of the things for me with my practice, I think about nutrition support because one of the things that happen to most people, they have lifestyle that is not right. They decide to eat 5 Krispy Kreme donuts or either go get bagels for breakfast. But they don't realize that the food that we eat for breakfast, most of the time, is not very healthy. And so one of the things I would like for you to do is, could you kind of hit on the point about the importance of good nutrition and whole food plant-based diet?
Yeah, for sure. And I actually was one of those mean doctors that told my staff, no, we're not allowing any more of those reps in because I don't want any more of the fried chicken and pizza coming through the door. But yeah, one of the things I offer in my practice is a lifestyle medicine membership. And what it is it includes their office visits as well as telehealth visits, as well as a library of plant-based nutrition resources and some nutrition counseling and coaching support along with body composition as a part of that. And so what lifestyle medicine encompasses is looking at nutritional support along with those other components to your health. So movement as well as sleep and stress, because all of those components will play a part in our health, and it'll play a part in the development of chronic health conditions. It can play a part if we're, getting those things into balance, into actually reversing those conditions. And excuse me, a lot of what I promote with nutrition is plant-based nutrition. I've been plant-based myself for over a decade now, and that was just based on me improving my own health. And then what I've seen over the years is the impact that I've been able to make on my patients in reversing their diabetes and getting people off of insulin and taking people off of blood pressure medicines just by making these dietary and lifestyle changes within them. A lot of studies, it's making more progress now in the medical field. It didn't years ago. Even, I came out of medical school in 2007, and even then it wasn't having the impact that nutrition is having today. And what more studies have shown us, though, is the impact of animal products on our health. Even the World Health Organization deemed hot dogs and bacon as cancer-causing foods, carcinogens. A lot of people don't even realize that, and, they may eat bacon every morning. And so it's just, really a matter of knowing what these foods and these food products are doing to us and how they're putting us at risk, and getting back to the basics. A lot of us come from cultures, especially in minorities, from farming cultures and farming practices where people had gardens and farms, and we grew our own food and we didn't eat as much processed food. And that's really the key, is getting back to those basics and consuming our food that way.
With that, we're going to sum this panel discussion up. Thank you very much for your participation.